Nephrotic syndrome, an important topic for the exam and the clinical purpose also. Students are having struggle with respect to answering this question in the Viva. So what is nephrotic syndrome? Before going into that, I want to mention in the textbook, if you take, most of the textbook they are starting directly with, it is constellation of symptoms of edema, proteinuria. They are directly starting with the symptoms. They are not explaining what is it. To understand nephrotic syndrome, if we take kidney, there are four important components: glomeruli, tubule, interstitium and vessel in the kidney. Nephrotic syndrome is the glomerular condition. It is nothing but a glomerular condition which is leaking the protein, which leading to all the manifestations. So what is the primary thing you have to start with is a nephrotic syndrome is a glomerular condition. Characterized by what? Characterized by the things that we are going to discuss subsequently. In the exam Viva, the sequence have to be correct. For the nephrology resident, the DNB Viva, they will be clearly noticing whether you are telling the order in sequence or not. So we will go to the first one. What are all the manifestations? First one to start with is the proteinuria. The glomeruli is leaking the protein, characterized by leakage. That is what the basic pathophysiology in nephrotic. Inflammation might or might not be there, because if inflammation occurs, that is nephritic. Sometimes superadded component might be there. Mostly it is non-inflammatory leaky condition of the glomeruli most of the time to describe it. So what is the level of proteinuria? The proteinuria will be massive amount. Normally a person excretes only 150 milligram of protein per day, whereas in proteinuria it will be more than 3.5 gram per day. More than 3.5 gram. 3.5 is very good for theory. For the MCQ, solving the purpose well and good. Clinically, let me give an example. If a patient is excreting around 3.4 milligram of protein per day, thus it doesn't fall under nephrotic. Or let us take a person is excreting 3.1 gram per day. As per the criteria, is not fulfilling. So for theory, 3.5 is correct. For practically, even approximately if it comes around 3 gram per day, you have to consider it as nephrotic, because there is a massive proteinuria. The values might be wrong because of the collection technique or during the processing, or patient might not have submitted exact 24-hour values. During that particular time, the urine might be very diluted. These kind of things can happen. So to detect the proteinuria, which is the best investigation, it is always 24-hour urinary protein. Suppose if not, you can go for the shortcuts like urine protein creatinine ratio or albumin creatinine ratio. Almost all suggest the patient is excreting more than approximately 3 to 3.5 gram. To be exact, for MCQ purpose, with 3.5 gram per day. So what will happen if there is a proteinuria? Protein is losing in the urine. Serum albumin, the albumin level in the blood will start going down. So this is the second manifestation. This is leading to this hypoalbuminemia. What is the albumin value? Lower than the normal, 3.5 and below, whatever the value. If the patient is excreting more than 3.5 gram, obviously albumin will start coming down. Higher the proteinuria value, lower will be the albumin level. Suppose if you are a medicine resident seeing this video, you can check in your wards. Whenever a patient is excreting more than 8 gram of protein in the urine, serum albumin will be approximately less than 1.5 gram or even less than 1 milligram. These two will go hand in hand. Many a times whenever a urine report is not reliable or there is some lab error, it is always the serum albumin which gives the clue what is the level of proteinuria. Another example, a patient with 24-hour protein of 1 gram, 1000 milligram, serum albumin is 1.2. Is it nephrotic syndrome? Which is more reliable? It is always the serum albumin. After ruling out patient is not having other causes of low albumin, if we take only kidney because of which patient is having low serum albumin, if urine protein value is only 1000 milligram, that indicates there might be faulty collection of the urine, or that urine sample might be wrong, because the serum albumin is a better correlator marker in nephrotic rather than the proteinuria. We can use it for a follow with this, but serum albumin is always more reliable. Whenever serum albumin is not there inside the blood vessel, the oncotic pressure won't be there. When oncotic pressure is not there, what will happen? There will be edema everywhere. Anasarca, lower limb there will be edema, periorbital there will be puffiness. Why there is particularly only periorbital puffiness? Because of the loose perialveolar tissue. Patient will be having typical periorbital puffiness because of the loose alveolar tissue. So this is the sequence. First to start with is a proteinuria, followed by hypoalbuminemia, followed by edema. Subsequent to this, because of the liver trying to produce more protein, lipoprotein also being produced, it leads to dyslipidemia. Lipid profile will be deranged. So the sequence have to be very clear. Apart from that, because of the protein loss, thyroid binding globulin will also be lost, because of which TSH will go high. In the medicine OPD, many a times or most of the times in a patient with a full-blown nephrotic, TSH will always be high. You can notice. You treat the nephrotic, TSH will start coming down. Vitamin D binding globulin will go low. The coagulation factor globulins, the protein which is having protein C, protein X, will also be lost. So these are all the sequence of this particular things. Okay, so to complete what is nephrotic syndrome, the definition you have to start with is the glomerular condition characterized by increased protein leakage across the barrier, which is characterized by, first to start with, proteinuria, which is massive, more than 3.5 milligram per day, followed by hypoalbuminemia. This is leading to this, this is leading to this, and this dyslipidemia is the final manifestation. Proteinuria, hypoalbuminemia, anasarca, and dyslipidemia. And because of that sequence, there will be loss of thyroid binding globulin, and subsequently the vitamin D binding globulin, other parameters we will be seeing. So this is what a correct definition of nephrotic, and don't be carried away by the particular urine ACR value or urine PCR, protein creatinine ratio value, or 24-hour urine protein value, because clinically the most of the times the faulty collection might be the reason for the low values. Better correlate with the serum albumin. Even it comes in the range towards nephrotic, it have to fulfill. You can't take that 3.5 as absolute criteria in the clinical practice. You can take it in the MCQ purpose, but for the clinical practice, it is a surrogate marker, not absolute marker. So this is all about nephrotic syndrome. Bye bye.